So what I'll present is a research question that I was confronted with about a year ago, I guess, at Janssen, where we had a compound, again for Alzheimer's disease, that we wanted to test in a phase 3 clinical trial. Now, can you go to the next slide?
Yeah, sure.
The Alzheimer compound was expected to work fairly well, or well, the best in patients that had already some memory complaints. So the question there is, can we identify patients or inclusion-exclusion criteria for a clinical trial where we select patients with what is called mild cognitive impairment? But we would like to have patients that are already pretty advanced, so on the verge of being diagnosed with Alzheimer's disease, or what is called conversion to Alzheimer's disease. Now, we don't want that conversion to happen too soon in the clinical trial, because the compound needs some time to work. So we expect that the patient needs to take the drug for at least a couple of weeks, maybe a couple of months, before clinical effects actually show up. That's the expectation before the clinical trial. So the question is, from the epidemiologist, can we identify patients that are mildly cognitively impaired, on the verge of becoming Alzheimer's patients or getting the diagnosis of Alzheimer's, but getting that diagnosis not too soon in the trial, because then we expect the drug not to have had enough time to work yet. So the question is, how do you identify patients like that? So, well, I'm an engineer actually. So if I need to do an analysis like that, first question is, yeah, okay, but what do you mean by conversion from MCI to AD? So if you go to the next slide. So these are the questions that I, as a technical person, cannot answer. What do you mean by conversion from MCI to AD? What do you mean by early conversion? What is early in the clinical trial according to your clinical insights? Which combination of baseline measurements could be predictive of early versus late conversion? That's something that the clinician needs to know. As a technical person, I might say, well, yeah, use a logistic regression model, and you'll find out. It will predict what the p-values are for each of your covariates, and therefore say which clinical measurements are important. But the interpretation is still with the clinician. Is a cognitive measurement suitable as an exclusion criteria for a clinical trial? Probably yes, it's easy to administer. Is an MR scan acceptable as an inclusion-exclusion criteria for a clinical trial? It's already more expensive. Maybe you don't want to do the cost for a patient that is 10 at the end, not included in your trial. Is a PET scan acceptable? Even more expensive. Is a lumbar puncture acceptable? That's invasive. You want to do that on a patient just to decide whether or not he or she will be included in the clinical trial. Things like that is something that I cannot answer as a technical person. That's something that a clinician needs to answer. And then for the measurements that he selects, what is the cutoff value? So when do you decide? Suppose you decide to include a cognitive measure in your clinical trial. What's the cutoff value then? When do you decide whether or not to include that patient in your trial? Well, you can use a survival analysis. Now, these are, well, I wouldn't call them pretty advanced statistical methods, but still, the clinician has some trouble with them. You can't really ask a clinician to write a SAS or an R program for a logistic regression or for a survival analysis. So what I want to really highlight with this avatar or with this presentation is that there's two kinds of users. One is the more technical, statistically data analysis oriented person that comes up with, yeah, okay, you ask these questions, but what do you mean by? And I can use a logistic regression to do this. And one is the more clinical user who needs to say, well, okay, but the logistic regression seems very predictive in separating early from late converters if you use a lumbar puncture and a PET scan. But that's not what I want to measure on a patient, just to decide whether or not he or she gets included in a clinical trial. Yeah. So how did this work in practice? Well, I implemented this in Spotfire. So not Transmart, sorry. Spotfire. Spotfire has some functionality where I can put in these degrees of freedom. So I can, for example, have this slider or this drop-down box or this action button here in Spotfire that says, you decide to the clinician, you're the Spotfire user, you decide what you mean by, in this case, early versus late conversion. So early versus late could, for example, mean convert on or before visit at month 18. Okay, but what does conversion mean? Well, conversion could mean a change in clinical diagnosis or a change in CDR, which is a clinical dementia rating scale, sum of boxes subscale. Well, if you choose the clinical dementia rating scale, how much should the patient change on that scale before you decide that he or she converted from MCI to VD? Well, in this case, 2 points. You can slide. And if you slide, you see the histogram change. This is actually the analysis that we did was on ADNI, phase 1 data, so ADNI 1. So in that cohort, based on the parameters that you select here, or that the clinician selects, you can immediately see, well, how many do I have? How many MCI patients do I have that now fall within the early converter or within the late converter state, or who actually stay stable, so don't convert. Okay, next slide. Once the clinician decides, well, I have 2 balanced groups, 18 months seems to be a reasonable time period in my clinical trial for conversion. There's a lot of measurements here, again in a list box here that you can select. If you hit so you select the number of covariates, you hit the calculate button. You can see here whether the groups are still balanced. You can see here whether the covariates that you selected are not collinear, which means that, well, that's a bit of a problem for your logistic model. These are the results of your logistic model with the p-values, either with all the covariates included, or with a cross-validated logistic model. For example, you see the ROC curves here. So the clinician has all the information there to decide whether or not his logistic model performs well, or performs at least good enough for his expectations, and whether or not he has taken the correct statistical precautions to make sure that his statistics are at least correct. And once he has selected a couple of covariates here that he thinks, well, these might be good covariates for inclusion-exclusion in my clinical trial. The logistic ROC curve seems to be good, which in this case is the case. Next. Then we go to a survival analysis and we say, well, for example, for an ADAS-Cog, so an Alzheimer's disease assessment scale, let's take this as a covariate. Cutoff at 7 and cutoff at 15, and let's see how fast these patients or these different subgroups convert. So patients with the highest score, which means the most heavily impaired on an ADAS-Cog, actually 50% of them already converted on or before visit at month 18. So half of them already got the diagnosis of Alzheimer's disease, whereas the ones with an ADAS-Cog score above below 7, sorry, so the most healthy ones, let's say, more or less stay stable. So there's not many of those that converted. So can we separate the two, for example, based on an ADAS-Cog score or based on a combination of measurements? That's the idea. So a person, a technical person or a statistician preparing the analysis, specific analysis in this case for a particular research question, but the clinician actually using the application and being guided towards